Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. There has been a huge increase in sexually transmitted infections over the past decade. There are no vaccines, and many of these infections can be hard to treat. Today, Stephanie Desmon talks to Dr. Matthew Hamill, an expert on STIs at Johns Hopkins, about a new tool in the works, having people take a dose of antibiotics after sex to prevent infections from starting. And research suggests it works for some. Let's listen.
Matthew Hamill, thanks so much for joining me.
Oh, it's my pleasure, Stephanie. Thank you for inviting me along.
So you're an expert in sexually transmitted infections, and I've been reading about something called DoxyPEP, and I'm wondering if you can please explain what that is.
Of course, Doxy stands for doxycycline, which is an antibiotic that we use to typically treat infections, but also to prevent infections. And PEP stands for post-exposure prophylaxis, which is a long series of words, but really what the idea is that an individual will take an antibiotic, doxycycline, after a sexual exposure to try and prevent them acquiring a sexually transmitted infection.
And what kinds of infections are we talking about specifically?
Yeah, so we're talking about bacterial sexually transmitted infections. So that is chlamydia, gonorrhea, and syphilis. They're the three infections that have been studied in the context of doxycycline PEP. They are really important infections for individual and public health. They're increasing in the US. So this is an important new intervention to try and address some of the increases in STIs.
I was going to ask sort of what the significance of this, there are no vaccines, oftentimes there's trouble with treatment. So talk to me, please, about why this is so important.
Sexually transmitted infections in the US have increased year on year. We've seen some really alarming increases in infections like syphilis. And when I talk with patients or colleagues or members of my family about syphilis, they say, really, syphilis is still a thing? Without recognizing that there has been huge increases in syphilis infection, both in adults and also in children. So babies born to mothers with untreated syphilis. So we've seen big increases in congenital syphilis in the US in the last decade. We've seen increases in gonorrhea, which is another sexually transmitted infection, and also increases in chlamydia, which is the most common bacterial sexually transmitted infection. You mentioned vaccines, and it's true that there is no vaccine for any of those infections. There is some work looking at an experimental vaccine against gonorrhea, but that's still in clinical trials and it's not available for use.
Mm-hmm. Well, I guess the question I have is, why are these infections increasing so much?
Yeah, that's the million-dollar question. I think if I had an answer for that, I would be preparing my Nobel Prize speech. So I'm not going to pretend that I can answer that question. But I think it's a combination of things. We have seen a real terms decrease in spending on sexual health services within the US. We have seen, particularly during or since COVID-19, that we've seen many services shrank because staff members were diverted to COVID activities. We were trying to decrease the amount of face-to-face time between patients and providers. And also there are other great interventions that are available, things like HIV prevention, whereby somebody takes a daily pill and effectively reduces their risk of HIV to close to zero. And there's some thought that these fantastic medications to prevent HIV may have an effect on sexual behaviors that increase the risk of other STIs. The truth is probably somewhere in the middle, Stephanie. It's probably a bit of all of those things. So, decreased access, changes in sexual behavior, and then the usual public health problems, stigma, and structural racism, etc. All of these things really play a role in the prevalence of STIs.
So there's some new CDC recommendations, and specifically, what do they say?
So the CDC are currently seeking feedback to a consultation document that they have put out around doxycycline PEP. There are data from randomized control trials, so they're kind of the gold standard scientific test to demonstrate that doxycycline PEP or DoxyPEP is effective. It does reduce the risk of chlamydia, gonnorhea, and syphilis in the region of 65 to 70%. So it's, patients are asking for it, even though it's not a CDC endorsed intervention right now. And it's something that people know about. People are really interested and motivated to take the medication. They want to avoid getting STIs. They want to avoid getting syphilis, that it can affect the brain and the nervous system and cause blindness, etc. And I think that the medical community is responding to that need. And as is so often the case, sometimes it takes guidelines a little bit of time to catch up with current practice.
So essentially, if I thought I was exposed potentially to an STI, I would take just a simple doxycycline, which we've all taken for some reason or another.
Yeah, so the way that DoxyPEP works is that a person is recommended to take 200 milligrams of doxycycline ideally within 24 hours after condomless sex, but up to 72 hours post-condomless sex. That's where the evidence is right now to show these large reductions in new STIs. It's 200 milligrams after the event.
And this is not for everybody.
There is really good evidence looking at the efficacy or how well this intervention works in men who have sex with men and transgender women. And I think that those data are really clear. There's been one study in cisgender women in Africa, which showed that providing women with DoxyPEP did not have an effect on STIs. So for that reason, I think that most providers will more sensibly recognize the sort of the limits of where the evidence is and will offer this medication or this intervention to men who have sex with men and transgender women. And I think there is no evidence to support its use currently in cisgender women and heterosexual men. But some of those studies are ongoing, and it's a huge area where we need more research and we need more data so that we can answer those questions.
Mm-hmm. And I guess the idea behind it essentially is that this pill would just prevent the STI from forming. It would just be a quick little shot of doxycycline into the system, and there would be no STI.
Yes, that's the theory. We know that it isn't 100% effective. There's no intervention that really is. So I think just being realistic about how efficacious DoxyPEP is, I think an intervention that reduces the risk of a new STI by 60 to 70%, let's say that as a reasonable ballpark, that's good. In biomedical terms, that is a great success for an intervention, but it won't prevent an infection in everyone. And I think that that's one of the really important communication parts with patients is that just to let them know that this intervention is not invincible. So if you develop symptoms, then it's important to get tested. It's also important to get tested regularly anyway, because we know that the vast majority of STIs won't have any symptoms to alert the patient or the individual rather to the fact that they have an STI. It's a great intervention. It's not a perfect intervention, and people really do need to keep up with testing or screening for STIs to make sure that they're not harboring an infection.
And there is downside here, right? I mean, there's definitely some cons here. Can you talk to me about those?
Yeah, there are definitely cons here. So doxycycline is a drug that we've used for decades. We've used it in in other forms of prophylaxis. So we've used it as long-term prophylaxis against malaria, for example. So we know it's safe. It has a good safety profile. However, there are side effects, and those side effects can be gastrointestinal. So people will complain of heartburn, nausea. It's important to give people really clear instructions about when they take this pill, to make sure that they're not taking it when they're lying flat, and then go and lie flat in bed, to take it with a large glass of water when you're standing up or sitting upright, just to allow the medication to go into the stomach rather than get stuck in the gullet or the esophagus. So that's one thing. Then the other issue with doxycycline is, in some people it will cause a photosensitive rash. So, and what that means is, if you take doxycycline and you go out into the sun, you can have a skin reaction where the skin can become, it essentially looks sunburnt, can be red and painful, and sometimes those skin side effects can be quite severe. And then there are other things that we worry about, on a more kind of biomedical, from that kind of point of view, rather than necessarily from a patient safety point of view, which is our number one priority. But we worry about the effects that doxycycline might have on something called the microbiome, and that's the bacteria that live in our skin, live in our guts, and we know that antibiotics can upset that microbiome, and there are all kinds of potential health consequences associated with that. And then I think the final thing that I worry about as a doctor working in infectious diseases is antibiotic resistance. So both in STIs and in other organisms as well.
And that could really pose problems if sort of too many people are taking preventive doxycycline.
Yeah, that's certainly a theoretical concern that doxycycline resistance could be driven by widespread use of doxycycline PEP. Sort of counter to that, the really important counter to that is that using doxycycline in this way is not taking a pill every day, or at least it's not for most people, depending on how much sex a person has, but generally it's not taken every day. So it's intermittent rather than continuous medication. And we know that patients have taken, doxycycline for months or years for treatment of acne or to prevent malaria. So that, antibiotic resistance is a big problem, and it's one that we all need to be cognizant of. But I just wanted to put in context that this isn't a medication that can typically be taken every day. And in the broad scheme of things, then I suspect that use of antibiotics isn't going to drive widespread antimicrobial resistance, but it's certainly possible, and we need to keep our eyes open for that.
And you said you've had patients asking for this. Do you see an uptick in that?
Patients ask for it. The results of these studies get presented at conferences, and the media reports the results of these important studies, and people can be extremely well informed, and they will learn about this intervention, and they will go to their provider and ask for it.
You think it's a good thing to give your patients?
I do. I think it's. I don't think it's a panacea, and I think that we have to be careful in terms of the advice that we give to patients, so that we couch this as one part and in one intervention in a suite of interventions that can help people to sort of have maximum sexual health. So I think it is important. It is important to be honest about what the limitations of both of our knowledge is, and also the limitations in terms of efficacy of the medication, and also to be upfront about some of the adverse effects that are possible, and the fact that there are things that we don't know. This is a relatively new endeavor in terms of STI prevention, so I think there's a lot that we still have to learn.
Matthew Hamill, thanks so much for joining me.
Oh, my pleasure. It was great to have the opportunity to talk about something that's very close to my heart.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.